Good evening and welcome to Queen's Free Speaking of Health lecture series. My name is Lisa Sakia. I'm with Corporate Communications here at Queen's Health Systems, and on behalf of Queen's, I welcome you all this evening. Tonight, this month is National Stroke Awareness Month, and so we're going to be discussing stroke, and tonight's lecture is called Advancements in Stroke Management. It is my privilege and pleasure to introduce you to our main speaker this evening, Dr. Ronnie Salem. If you could stand. He is a vascular neurologist and a neurohospitalist here at the Queen's Medical Center. He was raised in Los Angeles. He got his Bachelor's of Science in Psychology at the University of California, San Diego. He got his medical degree at New York Medical College, and that was followed by a neurology residency at the Kaiser Permanente Los Angeles Medical Center. He did his stroke fellowship at the Boston University Medical Center. He is also an assistant clinical professor of medicine for the Division of Neurology at the John A. Burns School of Medicine. Please join me in welcoming Dr. Ronnie Salem.
Okay, good evening, everybody. Thanks for having me, and thanks for coming. So today I'm going to be talking about some of the advances in stroke management. This is a very exciting time to be practicing stroke medicine. There's a lot of things changing, and a lot of new treatment options that we can offer patients now. So hopefully my goal tonight is to educate you guys so that you learn more than you ever thought you would need to know about stroke and can share that knowledge with your friends and family. So just a brief outline of what I'm going to talk about. So I'm going to just start with defining what exactly is a stroke and what are the signs and symptoms of a stroke. So how do you recognize when you or someone around you might be having a stroke, and who is at risk for having a stroke. And once you do spot these signs of a stroke, what do you do? And not only what do you do, what can be done for you when you have a stroke once you seek medical attention. And after you have a stroke, what are the important things that you need to focus on? So a way of thinking about stroke is it's a brain attack. Similar to a heart attack, a stroke is an acute neurologic injury to the brain due to either too much or too little blood flow. And this can lead to permanent neurologic deficits depending on which part of the brain is affected. Every part of the brain has a different function, and depending on which part of the brain is affected, you might see different types of signs or symptoms of a stroke. So the way we categorize strokes broadly, there are two main categories. The first being what we call an ischemic stroke. This is a type of stroke that occurs from a blood clot in the brain. And a blood clot in the brain obstructs blood flow in an artery to a specific portion of the brain, and brain cells are very sensitive to deprivation of blood and oxygen, and they start dying within minutes. And so the area of the brain that's no longer getting blood and oxygen can die, and the area responsible that brain is responsible for can lead to certain stroke signs, which we'll get to shortly. This is by far the most common type of stroke. However, the other type of stroke is what we call a hemorrhagic stroke. This is basically the opposite. This is a stroke that's caused by a ruptured blood vessel that leads to bleeding in the brain. And this bleeding in the brain can also cause similar signs and symptoms, but as an ischemic stroke, but they both happen for different reasons, and there are very different treatment options. The majority of my talk today is going to focus on ischemic strokes, since these are by far the most common types of strokes. But as we'll get to, a lot of the same rules apply in terms of prevention and things like that. So just some statistics I'm going to go over just to illustrate how prevalent of a disease this is. Here in the United States, stroke is the leading cause of disability. It is the number 4 cause of death in the United States, and actually the number 2 cause of death worldwide. And 800,000 people have a stroke in the United States every year, and surprisingly 600,000 of those people have actually had a prior stroke, which is very important because once you have a stroke, your risk of having a second stroke is significantly increased, and that's where really a lot of the preventative strategies are very crucial. About 130,000 people die from a stroke in the United States every year, and one person dies from a stroke every 4 minutes, and one person has a stroke every 40 seconds. So this is a very common and prevalent disease. A few more statistics. Over a third of people who have a stroke are actually younger than 65 years old. So this is not a disease just of the elderly. Strokes do not discriminate by age, and patients really can have a stroke at any age. And I mean, we see lots of young patients having strokes, so it happens across all age groups. There are similar rates between men and women in terms of stroke rates, but once you get into the age range of above 75 years old, there is actually a slightly higher risk for women compared to men above 75 years old. Strokes are more common among blacks, Hispanics, and people of lower socioeconomic status. And there's also a large economic burden of strokes, not just based on healthcare costs, but because strokes often lead to significant disability, there's a large economic burden in terms of work days lost by people who are no longer able to participate in the workforce. The good news, however, is it's estimated about 80% of strokes are preventable. So that's a lot of what we're going to be talking about today. This is a map that's basically showing different what the mortality rates are for stroke based on geographic region in the United States. So basically, very dark purple indicates a high rate of mortality from strokes, and the lighter purple indicates a lower rate. So if you can see here in kind of the southeast United States, a very dark purple. This is the part of the country with the highest mortality rate from strokes. This area is actually, we call this the stroke belt because of how prevalent strokes are in this area, and it's felt that that's from a lot of higher rate of high blood pressure, diabetes, and that sort of thing. In terms of Hawaii, if you look down here in the square, Hawaii is kind of about in the middle. So not doing as poorly as some parts of the country, but definitely some room for improvement. So here in Hawaii, strokes account for about 7 to 8% of deaths. It's the number 3 leading cause of death in Hawaii. And interestingly, Native Hawaiians and Pacific Islanders are actually 4 times more likely to die from a stroke than Caucasians. And further, Native Hawaiians and Pacific Islanders actually have strokes at much younger ages than other ethnicities as well. There have been studies showing that on average, Native Hawaiians and Pacific Islanders can have strokes 10 years younger than other ethnicities. A lot of that is felt to be due to a higher incidence of diabetes, high blood pressure, and obesity here in Hawaii, as well as limited access to health care, especially on outer islands, and a significant issue with methamphetamine use that we see here in Hawaii. So, as I alluded to before, ischemic stroke, this is the type of stroke where a blood clot blocks a blood vessel in the brain. This is by far the most common type of stroke. This accounts for about 87% of all strokes. So this is the majority of strokes. So again, a blood clot which can come from anywhere in the body, most commonly from either the heart or from traveling from another blood vessel up into the brain, or a blood clot just forming spontaneously in the brain. This can, again, cause a blockage of blood flow, and it's that loss of blood flow and oxygen that leads to brain cells dying. And once those brain cells die, that part of the brain is no longer functional, and then you lose the function of whatever that part of the brain is responsible for. So this is just a picture of a special type of CAT scan, just giving you an idea of when I say a blood clot, what does a blood clot actually do? So if you look at the picture here on the right, this is what the blood flow should look like on this type of imaging study. So if you follow the arrows up here, this is one of the main blood vessels going up into the brain, and then it has branches into 2 major blood vessels, and you can see that the blood flow is going all the way out, and this entire half of the brain is receiving blood flow without any obvious blockages. But if you look here on the left, there's an obvious abrupt cutoff of blood flow right here. So, and again, this is one of the major blood vessels. So this is a blood clot blocking a major artery in the brain. So a blood clot in this location would cause a major stroke. And so the idea of a lot of stroke treatment, which I'm going to be getting to shortly, is trying to figure out, number one, how to prevent this blood clot from happening in the first place, and then once this blood clot happens, is there anything we can do about it? So just to give you an example, this is just a regular CAT scan. This will be, for most stroke patients who come into the emergency room, the first test that they get. And essentially, when we're looking at a CAT scan, just for convention's sake, it's kind of like looking into a mirror. So this is actually the right half of the brain, and this is the left half of the brain. And the right half of the brain controls the left side of the body and vice versa. So you can see this grayed out area right here in the right half of the brain. This is indicating a large stroke that's already formed. Same thing, just another view, this image on the right, this all grayed out area, you can compare it to the other side. Here on this side of the brain, you can kind of see more detail, but over here it's just a big grayed out area. This is a very large stroke. When we see this on a CAT scan, that means the damage has already happened, and it's probably too late for us to really intervene at this point. This is another CAT scan. This is showing a very small stroke. This is what we call a small vessel or a lacunar stroke. So you can see this really small gray area here. This is on the left side of the brain. So we would expect to see some right-sided symptoms, and potentially weakness or numbness of the right side of the body. In terms of the degree of the symptoms, it's highly variable from person to person. I usually tell patients that you might see the exact same looking stroke on a CAT scan or MRI in 5 different patients, and they may all have varying degrees of symptoms. So there's a lot of variability from person to person. So hemorrhagic stroke, so this is the type of stroke that happens from a ruptured blood vessel, and this leads to bleeding in the brain. This accounts for about 10% of strokes. Sometimes even before the CAT scan, there are certain clues that can tell you this is more likely to be a hemorrhagic stroke rather than an ischemic stroke. Oftentimes with hemorrhagic strokes, because of the pressure from the blood in the brain, a lot of times patients may have a really bad headache, they may be vomiting, or they may come in and look very sleepy and not be as arousable as they should be. The highest incidence of hemorrhagic strokes is actually seen among the Asian population, which is something very important here with the Asian population here in Hawaii. For example, in Japan, 25% of all strokes are hemorrhagic stroke rather than the 10% here in the United States. And hemorrhagic strokes, they actually have a pretty significant mortality rate. About 1/3 of people with this type of stroke die within 3 months. So these strokes can be very severe strokes. And it's really because of the pressure. So this is what we're seeing here is another CAT scan, but compared to the other CAT scan I showed you, which had that gray area, which was a large stroke, this white stuff is the blood. And I'm showing 2 CAT scans taken at different times in the same patient, just to illustrate why these strokes can be so dangerous. So 2 hours after the onset of the stroke, you can see this white here, this is the amount of blood. So this is a very large area of bleeding in the brain, and you can actually see it's kind of already squishing on this part of the brain. It's starting to push the brain over this way a little bit. Just 4.5 hours after this, another CAT scan was done because the patient had clinically worsened, and you can see a lot more area of bleeding here. You can see some blood has spilled into what we call the ventricles, which is where normally spinal fluid should sit, and there's even more pressure pushing the brain over to the other side. So this is why these strokes can be very dangerous. So this is another example of a hemorrhagic stroke. Again, this is a much smaller one, but again, because of the variability from person to person, someone with a stroke like this might have very minimal symptoms to complete paralysis on one side of their body. So this is from a ruptured blood vessel. Most commonly, these types of strokes are from high blood pressure. Okay, so now we kind of know the 2 main categories of stroke. So how do you actually recognize if you or somebody around you is having a stroke? So typically a stroke is going to affect one side of the body. So you're looking for some type of asymmetry. And a way to think about the symptoms that you might have from a stroke is you're going to have some type of loss of function. So the most common signs or symptoms, you might lose the ability to move one side of your body. So you might have weakness of your face, which might be a droopy face. You could have weakness of your arm or weakness of your leg or all 3. You might lose sensation on one side of your body or feel numbness on one side of your body. You might lose the ability to speak or have impaired speech. So those are typically the really common signs of stroke that you'll hear about. But there are some less obvious signs of stroke as well. It might be simply a balance problem. You might have difficulty walking. You might lose vision on one side, or you might start seeing double. Sometimes a mild stroke can present with just incoordination of the hand, so the patient might just notice that they're dropping things out of their hand, they're having trouble handwriting or buttoning their shirt. It could be that subtle. Some strokes can present with just an inability to read, or vertigo, which is the sensation that the room is spinning. That's often a tricky one because the vertigo is not always a stroke, but if you've never had vertigo before and it's the first time you've ever had it, you should seek immediate medical attention. So as I kind of alluded to, no two strokes are alike. The symptoms of a stroke all depend on what part of the brain is affected, but one of the general rules of thumb is that if it's a stroke, it's going to be a pretty sudden onset. So that's one thing to keep in mind as well. And a lot of you may have seen this picture. This is a very common flyer that's used in a national public awareness campaign to try to raise public awareness for how to recognize the signs of a stroke. So the mnemonic used is FAST. So the F stands for face. So if you suspect you or someone's having a stroke, you ask them to smile. If one side of their face is drooping down, that could be a sign of a stroke. The A is for arms. So you ask them, or if it's yourself, lift both arms in the air. If one arm is drifting downwards, that could be a sign of a stroke as well. And the S is for speech. So if you ask somebody to repeat a sentence and they cannot repeat the sentence, they're slurring their words, they're having difficulty speaking, that could be another sign of a stroke. And then the T stands for time. And the reason is if you suspect or any of these signs, or you notice any of these signs in yourself or someone around you, time is crucial and you need to call 911 immediately. You don't drive to the hospital, you call 911. A very common mistake we see is patients either wait because they want to see if the symptoms will get better on their own, or the symptoms might be so mild that they are not too alarmed. But that's a big mistake. I can't tell you how many times I've seen somebody with their symptoms got better, they waited too long, but maybe they came to the emergency room, but a little bit too late, and the symptoms get worse again. Sometimes in the first day or two, stroke symptoms can fluctuate. They can get better, get worse. So even if the symptoms feel like they're getting better, if it's any of these signs that we discussed, you need to call 911 immediately. And the reason for that is, as we say, time is brain. It's estimated around 2 million brain cells die every minute once a blood clot blocks blood flow to the brain. And that's why it's so crucial for you to get to the emergency room as soon as possible, because the sooner you get there, the higher chance you have of us being able to offer you some type of acute treatment that can potentially reverse the effects of the stroke or minimize the damage done from the stroke. So who's at risk for having a stroke? So what are the common risk factors that put you at risk? So a lot of the common ones are what we call vascular risk factors. And these are your typical high blood pressure, diabetes, high cholesterol. A lot of it is really unhealthy lifestyle choices. So obesity, a poor diet, lack of exercise, or just being a physically inactive person can increase your risk for having a stroke. Smoking tobacco is a very big risk factor for stroke as well. And alcohol and drug use can also increase your risk for a stroke. And this is something we see in Hawaii a lot, as I alluded to with methamphetamine. We see a lot of strokes because of that. There are other causes of stroke other than those. An irregular heartbeat, especially one called atrial fibrillation, is a very common cause of stroke. And actually, statistically, atrial fibrillation tends to cause more severe strokes than other risk factors. So that's a really important one that if you have that, needs to be addressed. Obstructive sleep apnea is also a stroke risk factor, which a lot of people may not be aware of. Obstructive sleep apnea is where you actually, in your sleep, have periods of time where you stop breathing for short periods of time. And that stresses your heart and can, through different mechanisms, can actually increase the risk for a stroke also. Certain neck injuries can sometimes lead to a stroke. The main blood vessels that carry blood flow up to the brain are in your neck, and a tear in one of the blood vessels from some type of a car accident, a whiplash injury, some type of neck injury can lead to strokes also. So we tend to see that as well. There's something called a PFO, which stands for a patent foramen ovale. I'll get to that a little bit later in the talk, but briefly, it's a hole in the heart. A lot of people are born with this, but sometimes that can be relevant to a stroke, and we'll get to that a little bit later. Certain blood clotting disorders can lead to strokes. Certain autoimmune diseases, such as lupus, for example, can increase your risk for a stroke. Cancer actually can cause strokes also. People with cancer tend to be more prone to blood clots. So basically, this is why it's very important to be really proactive about your health, because it's been proven with lots of studies that the more risk factors you have, the higher the risk of you having a stroke. There's kind of a cumulative effect. Each risk factor increases your risk more and more. So knowing what these risk factors is very important to minimizing the chance of you having a stroke. And this is what I alluded to. Healthy lifestyle is, a lot of this is common sense. Really, a healthy lifestyle will go a very long way to helping you prevent not just a stroke, but heart attack and vascular disease in general. So this is, eating a healthy diet, limiting your salts, your sugars, and your fats, exercising regularly, being an active person. If you're a smoker, obviously quitting smoking, and then also knowing that if you do have some risk factors, a lot of them are what we call controllable risk factors, meaning that they can be treated sometimes with medications, which is why it's very important to have a primary care physician that you see on a regular basis. So you cannot control your age, but like I said, you can control most other things. These are controllable risk factors. All the risk factors I mentioned, for the most part, are things that can be avoided or managed medically or with healthy lifestyle. And as I said, each risk factor increases your risk for a stroke. Managing each risk factor will lower your risk for a stroke. So the converse is true as well. So there is an additive effect. So I like this graph just because it kind of illustrates what I'm talking about. So this is a graph showing what the estimated 10-year stroke risk is in somebody who's 55 years old. So the blue bars represent men and the red bars represent women. So the first column right here, column A, this is a 55-year-old person who's healthy with no known vascular risk factors. And you see that a pretty small risk of having a stroke within the next 10 years. We're talking 1 to 2%. Now let's say that patient, that same 55-year-old patient, now let's say they have high blood pressure, column B, that increases their stroke risk a little bit more. Now let's say they also, in addition to the high blood pressure, they also have diabetes. So that's column C, that risk goes up a little bit more. Same thing, now they're a smoker, the risk goes up. Atrial fibrillation, the risk significantly increased. Heart disease, now we're talking about 25% roughly. And like I said, the same is true. Now, let's say you have all these risk factors. If you treat them appropriately, that the stroke risk will come back down. So this just kind of shows the cumulative effect. So this is why it's important that you have a primary care physician. If they think you need medications to control these risk factors, it's very important to be compliant. And again, devising a diet plan, joining a gym, or having some type of structured exercise regimen, and a smoking cessation program if you're a smoker. These are all things that you can do to be proactive and really minimize your chance for having a stroke. I show this because I recommend all my patients to have a blood pressure monitor at home and to actually keep a log, checking their blood pressure at least once a day. The reason for this is if there's one thing, probably the most effective thing you can do to prevent a stroke is keep your blood pressure controlled. That will go a very, very long way to minimizing your chance for a stroke. And it is very helpful to your physician if you keep track of your blood pressure at home so that they have an accurate idea of how well controlled your blood pressure is. If you don't keep track of it at home, you don't check it at home, and the only way they're going to know is the one blood pressure you have in the doctor's office. That doesn't tell them what your blood pressure has been the last week, the last month. So you keeping track of it at home makes it a lot easier for your doctor to know, is it well controlled, is it not, do you need to be on medication, does your medication need to be adjusted? So that is very important. If you're diabetic, this is a glucose monitor. So just the same idea as blood pressure. If you have diabetes, you need to keep very close eye on your blood sugars to make sure that they're well controlled as well. So I kind of alluded to obstructive sleep apnea. Basically, this is a condition caused by partial airway obstruction when you're sleeping. So you have brief periods of time of what we call apnea, where you actually stop breathing for a few seconds, you're gasping for air, and that stress can increase blood pressure, it can trigger an irregular heartbeat, and especially atrial fibrillation, and it's been estimated that having obstructive sleep apnea doubles your risk for a stroke. The most common symptoms of sleep apnea are either being a heavy snorer or having a lot of daytime sleepiness. So if you have either of these two, you might want to ask your doctor about maybe getting checked for sleep apnea. The way that this is tested for is with what's called a sleep study, where you're monitored overnight to see if you have these periods of time where you stop breathing. And again, just like high blood pressure, just like diabetes, this is a treatable risk factor. So if you have sleep apnea or you know anyone that does, this is a CPAP machine. This provides continuous oxygen flow while you're asleep. Probably the biggest problem with this is that for some people, this mask, if you look here on the left, this is the traditional mask. It can be very cumbersome and annoying for some people, and some people just cannot sleep with it. There are newer devices on the market. So for example, on the right, this is a nasal CPAP. It only covers the nose. It's a little less bulky. There are other options on the market now. In terms of, I mentioned diet being very important. The diet we usually recommend for stroke prevention is the Mediterranean diet. This is a diet that's actually been shown with clinical studies to reduce the risk of stroke, as well as heart disease, osteoporosis. So there are multiple health benefits of this diet. It's also been shown to improve brain function when testing memory and thinking, problem solving, and planning skills. So this is a pretty common diet these days. Has gotten a lot of publicity, and you can find information on it all over the internet. But kind of the mainstays of the diet is heavy on fruits and vegetables, olive oil, nuts and seeds, grains, lentils, beans, dairy, fish, and poultry. And this is just kind of a schematic on kind of how they recommend you follow the diet. So everything here in green, everything below here is what's recommended that's okay to eat on a daily basis. And that includes whole grain foods, pasta, potatoes, fruits, vegetables, nuts, some dairy, and again, olive oil is a big part of the diet. And then on a weekly basis, poultry or seafood, eggs, and maybe on a monthly basis, treating yourself to red meat. And they do allow for some wine and red wine in moderation, and advocate drinking a lot of water and daily physical activity. So this is the diet that we do recommend to all our stroke patients, and even before they have a stroke as well. Okay, so those are risk factors we've talked about how to recognize the signs of a stroke and why it's so important to call 911 and get to the emergency room so quickly. So what do we actually do when you come to the emergency room? So the acute treatment of an ischemic stroke, so again, stroke from a blood clot. So the mainstay of treatment for over 20 years has been a medication called Alteplase, or TPA. This is a clot-busting medication. We give this medication intravenously. The caveat is we can only give this medication up to 4.5 hours after the onset of the stroke, which again is why it's so crucial to recognize the signs of a stroke immediately and call 911 to get to the emergency room as soon as possible. There are certain criteria in terms of who can get it, because again, this is a very potent blood thinner. So there is a small risk of bleeding associated with this medication, which is why if for example, if you've had a major surgery recently or recent head trauma, or you're someone who's known to have a high risk of bleeding for whatever reason, it may not be safe to give you this medication. So these are some of the decision making we go through when a patient comes into the emergency room. And this medication can increase the chances of you having a good functional outcome if a patient has a stroke. The earlier the medication is given, the better the chances are of a good outcome. And again, that goes back to the idea that you're losing brain cells every minute, 2 million of them. So the sooner that medication can be given, and the sooner that blood clot can be dissolved so that the blood flow is reestablished, the more brain cells you're going to save. And in best case scenario, this medication does have the potential to completely reverse the effects of the stroke, which is something we do see when patients get there early enough. If the blood clot is small enough and amenable to treatment, we see some patients come in completely paralyzed or unable to speak, and after the medication, they're back to normal. So that it does happen. It doesn't work for everybody, but the earlier you get there, the better chances are of that happening. However, we do know that this medication is not as effective for large blood clots. And so even if you get there on time and you have a very large blood clot and we're able to give you this medication, that's no guarantee that it's going to work and actually reopen the blood vessel. So that is where what we call endovascular therapy comes into play. So there's a procedure called mechanical thrombectomy. If any of you have ever had any stenting procedures or angiograms done on your heart, it's a very similar procedure where a catheter wire is inserted through your groin into the femoral artery, and the wire travels all the way up through the blood vessels in your body, through your heart, and up to the brain. And basically, under live X-ray, the interventionalist or the physician who's performing the procedure can see a live look of what the blood flow is looking like, can identify exactly where the blockage is, and there's a device attached at the end of the wire that can actually physically pull the clot out. And again, these are for large blood clots. And there's actually was a major breakthrough this year in stroke treatment. Traditionally, up until a few months ago, we could only offer this treatment up to 6 hours from the time of stroke onset. However, just within the last few months, there have been some new clinical trials that have now shown that in select patients, we can actually treat people up to 24 hours from after the stroke onset, which is very major news for the stroke world and for patients who suffer from strokes. Because before, with the 6-hour time window, excluded a large amount of patients, and a lot of patients with stroke wake up with symptoms. And the way that we normally would decide on treatment was going by the time that the patient was last normal, and that excluded most patients who went to bed at 10 p.m. and woke up at 6 or 7 a.m. with a stroke. We were not able to offer them treatment. So now those patients, if they meet certain imaging criteria using advanced imaging techniques, we can now offer treatment up to 24 hours. So, and this also goes for patients where we're not entirely sure of the time of onset. Maybe they live alone or they were found at home on the ground or something like that. So this really expands our treatment window and the amount of patients we can offer treatment to now. So this was a big change this year. And as I mentioned, advanced imaging techniques, this is just to give you an idea. I showed you some CAT scans earlier. The advanced imaging techniques that we use to select patients that we can treat in those first 24 hours uses specialized software that kind of shows us how much brain there is left to save, essentially. So without getting too technical, if you look at this picture here, the column on the left, this red area is essentially telling us this is brain tissue that's already permanently damaged. But if you see all this green area this is area that's at risk. If we're not able to open up the blood vessel, all this area is going to die, and this will end up being a massive stroke. But it has not died yet. So if the blood vessel can be opened quickly enough, all this area can be saved. So this is kind of the specialized imaging we go through when we decide on if it's safe to offer treatment to patients in that 24-hour time window. If we do take a patient for the procedure, they'll go into a room that looks like this. This is an angio suite, and you can see some screens here. This is where the physician will be looking at the actual images in real time, seeing where the blood clot is, where his wire is, and can actually see the blood flow being reestablished if he pulls the clot out. This is done with live X-ray. So these are examples of what the images that we're looking at during the procedure look like. So the picture up here on the upper left, so similar to a picture I showed you earlier in the talk, but basically showing a abrupt cutoff of blood flow in one of the major blood vessels. And essentially, during the procedure, as the wire moves all the way up through this blood vessel, and to try to pull this blood clot out and restore blood flow, you start seeing the images change, and you start seeing more blood flow being reestablished, until finally, in this picture down in the bottom right, now the blood vessel is completely open, the clot's been pulled out. So I'm going to show just a quick video of kind of what happens during this procedure.
Treatment of acute ischemic stroke with clot retrieval device. Ischemic stroke is a condition in which normal blood flow to the brain becomes interrupted. When a clot becomes lodged in one of the arteries that supplies blood to part of the brain, the tissue is deprived of oxygen. Clot removal devices are designed to treat ischemic stroke by removing the blood clot from the artery. The clot removal procedure begins by advancing a guide wire through the blood clot within the artery. A microcatheter is advanced along the guide wire until it is beyond the clot. The guide wire is retracted and the clot retrieval device is advanced through the microcatheter and deployed as the microcatheter is retracted. Once unsheathed, the device expands, pushing the clot to the walls of the artery and immediately restoring partial blood flow. Over the next 2 to 5 minutes, the device becomes embedded in the clot. The clot retrieval device, along with the blood clot and microcatheter, are removed from the body. Blood flow is restored and verified with imaging. The entire procedure typically takes less than an hour.
Okay, so that's the acute treatment when somebody comes in with a stroke. So after the patient is stabilized, once we decide whether or not they can be offered any of these treatments, the next important thing is trying to figure out what the cause of the stroke was. A lot of different things can cause a stroke, and it's important to identify what the cause was because it might change our treatment plan in terms of preventing a second stroke. And this is just to kind of give you an idea of the thought process that we go through. This is not a comprehensive list, but just to give you an idea of the different treatment options in terms of preventing a stroke. Because again, doing all these diagnostic testing to try to figure out what the cause of the stroke is, it's not really to treat the stroke the patient just had, it's to prevent the second stroke from happening. So for example, if we see that the patient had a stroke because they have narrowing of a blood vessel in the neck, specifically in the carotid artery, that patient might need a surgery to clean out the plaque. If they have narrowing of a blood vessel inside the brain, we usually don't do any surgery except in very rare situations. For the most part, we will treat those patients medically, and they might need a little bit more aggressive blood thinning medication, usually with a combination of 2 blood thinners. And usually those blood thinners are aspirin plus something like Plavix or Brilinta. Those are some of the common medications we use. If someone is found to have an irregular heartbeat like atrial fibrillation, then we use an even stronger class of blood thinners, and those include medications like warfarin, or which is an old medication, or some of the newer blood thinners on the market now, like Eliquis, Pradaxa, Xarelto, which you might see are all over the TV and with commercials these days, but they are effective medications. Again, there are patients who have atrial fibrillation, but it may not be safe for them to take these strong blood thinners because they might be considered too high of a bleeding risk for whatever reason. Maybe they have a bad ulcer that bleeds or whatever other reason. There's a procedure that can be done for these patients that can actually, allow them to avoid having to be on lifelong strong blood thinners. And then again, for example, if somebody's found to have a PFO, that hole in the heart that I alluded to earlier, that's something, and if it's felt that that's the cause of the stroke, then we can do a procedure, or the cardiologist actually can do the procedure where we actually close up and seal that hole off. So just to kind of give you an idea that a lot of the tests we do in the hospital are to identify the cause of the stroke so we know how to prevent another one. So in terms of preventing a second stroke, the very same rules apply. It's really about reducing risk factors. So again, blood pressure, cholesterol, diabetes, all the same sort of things. But now, when someone has a stroke, now the blood thinners become very crucial in terms of preventing strokes. So there's really 2 categories of blood thinners, 2 general categories. The first one is what we call antiplatelet medication. So of that, the most common one is aspirin. And then some of the other ones include medications called Plavix, Brilinta, or Agranox. Those are the ones most commonly used. And then the other category of medications is blood thinners is anticoagulation. So these are strong blood thinners that are most typically used for patients who have had a stroke from atrial fibrillation. And so again, warfarin or Coumadin is the other name for it. It has been around, that's the one that's been around for over 50 years and has been traditionally used. But this is a very inconvenient medication. You have to get regular blood checks. It interacts with a lot of other medications. There's some dietary restrictions. So luckily, now that we have these newer medications like Pradaxa, Eliquis, and Xarelto, that's really changed how we can treat patients who have atrial fibrillation. And you don't have to get any blood tests with these medications. They're much more convenient, and there's about a 50% lower chance of bleeding in the brain, which is really the most feared side effect of these medications. I just want to say a little bit something about Plavix, or the other name for Plavix is clopidogrel. This is also a commonly used blood thinner for stroke prevention. This is an antiplatelet blood thinner. And I think this is a relevant issue to bring up here in Hawaii because of our large Asian population. Some people have a genetic mutation that affects how they metabolize or break down Plavix. And these mutations are actually much more common in Asian patients. So some people who have these mutations are what we call poor metabolizers. So for Plavix to work, it has to be metabolized into its active form. And if you're not able to metabolize it, you're not going to get the blood thinning effect of the medication. So there is a genetic test that can look for this to see if you are one of these poor metabolizers. And we found here in Hawaii that this is a very common issue. And so I do at this point now tell all patients that if they're on Plavix, they should probably, especially if they're Asian, they should probably get screened for this. And if they're a poor metabolizer, you might want to talk to your doctor about maybe if another blood thinner might be a good idea for you. So I mentioned with atrial fibrillation, we use the anticoagulant medication. They're very strong blood thinners. And again, the main risk of these medications is bleeding. So there are some patients where it's not safe to use those medications. So fortunately, there's a new procedure that can be done for these patients who are high risk to take these medications but have atrial fibrillation, which again, without blood thinning medication, can really lead to a high risk of stroke. And again, they tend to cause more severe strokes. So I'm going to show a quick video just on this procedure that can be done for these patients.
Nearly 1 out of 3 AFib patients will have a stroke. But why are they more likely to have a stroke than people without AFib? For patients with AFib, over 90% of stroke-causing clots that originate in the heart are formed in a structure called the left atrial appendage, or LAA. Everyone has a left atrial appendage. It is a small pouch that sits off of the left side of your heart. AFib may cause the blood being pumped through your heart to pool in the LAA, where it gets stuck and can form a clot. If that clot escapes and gets into your circulatory system, it can block the blood supply to the brain and may cause a stroke. Today, a number of treatments are available to reduce this risk of stroke. Blood thinners such as warfarin or Coumadin have been available for more than 50 years. But blood thinners affect the entire body and may not be well tolerated by everyone. They may have side effects like bruising, nosebleeds, gastrointestinal bleeding, or, more importantly, if the dosage is not properly maintained, an increased risk of hemorrhagic strokes. Plus, some blood thinners like warfarin require going to a clinic for INR checks and may incur out-of-pocket expenses. But there is a new treatment option that eliminates the need for long-term INR checks and the need to take daily prescription blood thinners. The WATCHMAN device is an implant-based alternative to blood thinners such as warfarin. The WATCHMAN implant is designed to permanently seal off the LAA, where blood clots can form. The WATCHMAN implant is about the size of a quarter. The implant does not require open heart surgery, and the device cannot be seen outside of the body. As in a stent procedure, your doctor will guide the WATCHMAN implant via a catheter through a vein in your upper leg and into the left side of your heart. Once there, your doctor will release the implant to seal off your left atrial appendage. The whole procedure typically takes less than 1 hour. You would then need to stay in the hospital overnight, and recovery typically takes about 24 hours. Over time, heart tissue will grow over the WATCHMAN implant and the LAA will be permanently sealed off. In most cases, patients were able to discontinue blood thinners 45 days after their implant. The WATCHMAN implant offers patients with AFib a potentially life-changing stroke risk treatment option, which could free you from the burden of long-term warfarin therapy forever.
So that is an option for people who cannot take blood thinners or are felt to be unsafe to take blood thinners. All right, so I'm going to move on and talk about something called a cryptogenic stroke. This is a type of stroke. We're still talking about strokes caused from blood clots, but this term is referring to strokes where we don't know what caused the stroke. Despite doing all the testing in the hospital, it's surprisingly, this is very common, and almost 1/3 of all stroke patients, despite doing all the testing, we don't find a definitive explanation for their stroke. So this is a very challenging part of stroke treatment. A lot of research has suggests that maybe a lot of these patients have atrial fibrillation that we're just not diagnosing on the monitor, because a lot of patients with atrial fibrillation don't have any symptoms. But we're not entirely sure, and essentially, there's still no consensus on the best way to treat these patients in terms of what type of blood thinners to put them on for prevention of a second stroke, for example. So for these patients, because there's a high chance they might have atrial fibrillation, we tend to look longer for atrial fibrillation. And so there's ways we do that after these patients leave the hospital with different types of monitoring devices. So there's a device called a Zio patch, which we will refer for a lot of our patients to get, which is essentially a patch you just stick on your skin, and it can stay there for 14 days, and it constantly monitors your heart. There's no wires, you can shower with it, and after the 2 weeks, you take it off and mail it in, and we'll get the results to see if you had any atrial fibrillation. The reason that's important, like I said, if you have atrial fibrillation, you need to be on one of those stronger blood thinners, or potentially the procedure I just showed you, the left atrial appendage closure. If after 2 weeks we don't find atrial fibrillation and we have a high suspicion that you might have it, sometimes we'll refer patients to get what's called a loop recorder or an implantable cardiac monitor. Essentially, they look like very small USBs that can be injected under the skin, and they have a battery life that can last for 3 years or longer, and it's basically you're constantly monitoring your heart rhythm for any irregular heartbeat. So we will do this sometimes for patients who we suspect might have atrial fibrillation, but we haven't been able to catch it on a monitor yet. Okay, so I did mention the PFOs earlier a couple times, so I'm going to talk a little bit about that. PFO stands for patent foramen ovale. This is a hole between two chambers of the heart, between the right and the left side, and actually 25% of the general population has one of these, and we're born with it. And most of the time it's not really clinically relevant, but this is something that when somebody has a stroke, especially a cryptogenic stroke, meaning we don't know why they had the stroke, and they have a PFO, it's been historically it's always been a question in the stroke world of whether or not you should go and close them. And this has always been a controversial area, and as of right now, there's still two schools of thought, but for the first time last year, there were a few studies that came out that have kind of influenced the way a lot of stroke neurologists are practicing now, that did show that there is a benefit in reducing the chance of stroke. If your neurologist thinks your stroke is related to the PFO, he might refer you to a cardiologist for this procedure. And conceptually, the way that this can cause a stroke is if somebody has a blood clot in their leg, the fear is usually that the blood clot can travel up and go to the lung. However, if you have a PFO, if you have a hole in your heart, if that blood clot in your leg travels up to the heart, instead of going to the lung, it can bypass the lung by going through that hole, and that can shoot it out into the general circulation, and then that clot can go up to the brain and cause a stroke. So the idea of the PFO is, of closing the PFO, is to prevent that clot from being able to leave the heart and go up to the brain. And the procedure done for that is very similar to the procedure I showed, the left atrial appendage closure. Same idea, it's basically putting a little mesh in that hole to seal it off with the same type of procedure through the groin. It's not an open heart surgery, but that's something else that the cardiologist can do if we feel it's necessary. So You know, a lot of what I talked about is really, other than the acute treatment for a stroke, is about preventing a second stroke, because like I said, once you have a stroke, the risk for another stroke is significantly higher. But a lot of these medications and these treatments, you know, are not really designed to help you recover from the stroke that just happened. So really that's where rehab comes into play, and the rehab is really where patients get a chance to increase their, regain some of the function they may have lost from the stroke. So if they have weakness on one side of their body, physical therapy and occupational therapy are very important. If they have speech deficits or swallowing problems from a stroke, a speech therapy becomes important, as well as cognitive therapy, because strokes can affect your memory as well as your speech. And so this is just kind of giving you an idea of some of the different things that people work on after a stroke in terms of rehabilitation, working on avoiding falls. If you're weak in one of your legs, or your balance is affected, or your sensation is affected, you're at risk of falling. Obviously, being on blood thinners and falling is dangerous, so even more reason why that's so important. Working on just being able to get back as much of your independence as possible, and that's where the rehab comes in. There's a lot of work being done in robotics these days with rehab therapy, with more technology coming out, offering very technologically advanced ways to rehabilitate after a stroke. And I'm just throwing this in there. Acupuncture there is some anecdotal evidence that acupuncture can help with stroke rehab. So a lot of patients ask me about it, and there's no harm in it, and I have a lot of patients tell me they think it helps. So I think it's something that's worth trying. So my take-home points for tonight: stroke is a very serious and a global prevalent disease. Time is brain. That's probably the most important thing. So again, you spot any signs of a stroke, getting to an emergency room by calling 911 as soon as possible is crucial. You have the power to significantly reduce your chance of having a stroke by focusing on all the risk factors we talked about. And again, if you unfortunately are to have a stroke, the treatment options are growing now. There's a lot more patients we can treat now, and a lot more patients we can help to either prevent a stroke or minimize the damage done from a stroke. So I hope you take what you learned tonight and educate your friends and loved ones. Thank you very much, and I'll open it up for questions.
Okay. Yes, Dr. Salem. If you have a question, raise your hand. Okay, we have one here.
Are there any gender differences in the signs of a stroke, like there are gender differences in heart attacks?
No, there are not.
Okay, so
I want to ask about the perforated foramen ovale. You said that by closing the perforated foramen ovale, there's a chance that will reduce strokes, but is there an increase in ischemic attacks in the lungs with that procedure?
No, there's not. Actually, interestingly, one of the, so the question is if there's an increased risk of blood clots going to the lung if you close the PFO. And no, that procedure does not increase that risk. The procedure, one of the risks associated with that procedure, ironically, actually is there is a small risk of atrial fibrillation being caused by the procedure itself. But in terms of a blood clot going to the lung, there is no association of that, really.
Thank you, Doctor. Very informative lecture. And referring to the map that you showed earlier, the incidence of stroke.
Right.
And since 2/3 of stroke occur in the elderly, it seems counterintuitive. Arizona and Florida have the least amount of strokes, which has the highest elderly population. How do you account for that?
Good question. I don't have a good answer for that. I would be speculating, but my sense is that a lot of patients that go there are elderly patients who are perhaps still active enough to be active and live in sunshine and be outside more. So maybe they're just more physically active. But I'm not aware of any science or any data that has an explanation on that.
Other questions?
I just had one. In the South, you have to live in the South, Tennessee, and their diet is mostly fried foods.
Yeah.
And so I think it's mostly your diet.
I think a lot of people think that too.
Yeah, sausages, yeah.
Yeah. That's why there's so much more diabetes. Diabetes is much more prevalent there as well. So it goes hand in hand.
Can you explain about aneurysm with, in regards to strokes?
Yes, sure. So an aneurysm, that causes a different kind of stroke. So an aneurysm is essentially a blood vessel problem. An aneurysm is where a blood vessel wall is weakened and kind of it creates an outpouching of the blood vessel wall so that it becomes more prone to rupturing. And it causes what's called a subarachnoid hemorrhage. So that's a very different type of stroke. Most of that type of bleeding, most of the bleeding is actually not inside the brain itself. The bleeding is actually along the linings of the brain. But it is a very devastating cause of stroke, and actually that can be, that type of stroke can be very fatal early on, and it can be seen in younger people, and there is a slight familial relationship, meaning that if you have a family member who's had an aneurysm, you should probably screen yourself for one also.
Hi, doctor. So you made a reference to the CYP2C19 gene mutation. So a lot of these new DNA testing things like 23andMe offer identification of certain markers. To your knowledge, is that one of them that they identify, or do you still have to go to your physician to actually get that tested?
As far as I'm aware, I think your physician has to refer you for that test because it's not a test that's done here in Hawaii. It's actually a send-out test to the mainland. So I think only a few laboratories do that test. So I don't think that's something you can go and get on your own, as far as I'm aware.
Okay, doctor, question is, can you explain the term mini stroke and should there be an area of concern about it?
Okay. So I don't like the term, so he's asking to explain the term mini stroke. I don't like that term mini stroke. I think it can be misleading. A lot of people that can have different meanings to different patients and to different physicians. So I think in my experience, when patients tell me I've had a mini stroke before, most of the time I think that means what we call a TIA, or a transient ischemic attack. That's different from actually having a small stroke. A transient ischemic attack is where you have signs or symptoms of a stroke, but they don't last long enough to actually cause any permanent brain damage. Some patients can have what other people call mini strokes might be very small strokes, or maybe they had very mild symptoms. Maybe their symptoms got better, but they're actually on the CAT scan or MRI, there's actually a stroke. There's actually brain damage. And that's very different in terms of treatment implications. So that's why I don't think it's a good term because it is very misleading. So if you're talking about a transient ischemic attack or a mini stroke, meaning a small stroke, those are two very different things. So that's how I would approach it. That's why when patients tell me they've had a mini stroke before, I always ask them, what do you mean exactly?
One of the alternatives that you talked about, or solutions, was that left atrial appendage closure. So is that based on the fact that that appendage causes more clots in the body than anywhere else?
So the question is about the left atrial appendage closure procedure, and so essentially the thought is that people who have atrial fibrillation, that the majority of the blood clots that form from that irregular heartbeat form in the left atrial appendage. So over 90% of the clots that form because of that irregular heartbeat form in that very small appendage. So the idea is that if you seal off the appendage where most of the clots form, the clots no longer have the ability to escape the heart and travel out up to the brain. So that's the idea behind the procedure.
Okay, we'll do one last question.
I'm curious about the clot removal treatment. How long has that been used at Queens? How often does it get used? Is it available at other medical facilities? And is this a treatment that's done right when the patient comes in after a stroke, or can it be done, say, 3 months after the stroke?
Okay. So good question. So the question is, how long has the clot retrieval procedure or the mechanical thrombectomy procedure been done? Do we do it at Queens, and what's the time period of when we can offer that treatment? So it has been done at Queens for a long time. It's not able to be offered at every facility. Actually, we are a facility that we work with a lot of the outer island hospitals, so that cannot offer this procedure, and other hospitals on Oahu. So oftentimes patients who need this procedure come here to Queens for the procedure. So it is done very often. We have a the type of doctor that does the procedure is what we call a neurointerventionalist. So it's a different type of neurologist. He's a procedural neurologist who goes in and treats strokes with this procedure and treats aneurysms, for example. And basically, he does have a, this procedure is something that has been done fairly regularly. Now that we've implemented these new changes where we can treat people up to 24 hours, it's being done a lot more right now, a lot more frequently. We've gotten a lot busier as doctors here because of this change. And in terms of your question about can it be done 3 months later, absolutely not. It has to be done, like I said, within 24 hours. Because the whole idea of why there are strict time limits to these procedures, if you open up a blood vessel that's blocked already too late, that implies that the damaged brain tissue is already dead, and dead brain tissue cannot absorb blood. So if the brain tissue is dead and all of a sudden you open up the blood vessel, then that patient is going to have massive bleeding in their brain. So that's why if you're already seeing a large stroke on the CAT scan or on the imaging techniques we use, that means the damage is done and it's too late to open up the blood vessel. So it has to be, the whole idea is to prevent the damage from happening in the first place, so that's why it has to be done immediately. Oh, okay. Thank you.
Okay, how about another round of applause for Dr. Ronnie Salem? Wasn't that totally information-packed about stroke amazing? I also want to say mahalo to Jennifer Moran. I'm not sure if she's still here, but she's the neuroscience stroke coordinator, and she was the one outside giving out all that great information, those free magnets, the cards, so everyone's going to know about FAST and can share that with others in their lives, right? And I also want to say mahalo to our Queens volunteers outside who were checking people in. That's Karen Sumida, Bertha Kawi, and James Liu. Let's give them a warm round of applause. And our next Speaking of Health lecture coming up June 27th, Wednesday from 6 to 7 p.m. It's not a topic we've covered before. It's on sarcoma, which is a type of cancer. It's the forgotten cancer. And it can originate, it's a deadly cancer that can originate in muscle, in fat, bone, and many other sites. And we're going to have Dr. Shane Morita, who is the Queens Medical Director of Surgical Oncology. He's also a MD Anderson Cancer Network certified physician who's going to be talking about the forgotten cancer, sarcoma. He also will have some patients who are going to be sharing their experience with sarcoma and their journey with this cancer. So it's going to be very interesting to hear from them. You're going to learn what is sarcoma, how many types exist, who is at risk for sarcoma, where can it occur, and what is the best way to treat it. If you're interested in attending that, you can register by calling 691-7117, that's our Queens referral line, or go online to queens.org and click classes and events to register online. That's going to do it for us this evening. Thank you so much for coming. Take care and drive safe. Have a good evening.